Good evening, everyone, and welcome to this webinar, our third series of the primary healthcare performance management webinars. And today we are going to learn about the role of leadership in implementing primary healthcare reforms in Kenya. The title for the webinar is Leaders as Catalysts of Change in Implementing PHC Reforms. And we have two very experienced county leaders as part of our plenary speakers today. I'll invite them to introduce themselves. My name is Dr. Sally Ndongo, Knowledge Management Specialist at Hector Consulting. I'm stepping in for Dr. Brenda Obondo, who will pick up the moderation in a few minutes. But at this point, I'd like to welcome our two speakers to introduce themselves. We'll start with Dr. Oda and then move on to CC Roslyn. Dr. Oda, please.
Thank you, Daktari. Good evening. My name is Dr. Oda Kone Mirimo. I'm a family physician by training. Currently, I head two divisions in Nairobi City County, the Division of Primary Healthcare and the Division of Family Health. I'm also a board member for Kenya Red Cross, Nairobi branch, and also NGC member of Kenya Association of Family Physician. For the prior, I had the Resource Mobilization Committee, and for the latter, I had the Audit Committee. Happy to join you this evening.
Thank you so much, Dr. Oda. We look forward to learning a lot from you on your experience in Nairobi County as the PHC and Family Health Lead. I'd like to welcome the CEC for Nakuru County to also introduce herself. Karibu Waziri.
Thank you very much, Daktari. And my name is Roslyn Mungai, County Executive Committee Member for Health, Nakuru County. And I'm also privileged to serve on the board of the Social Health Authority. I implement Governor Susan Keka's manifesto for health in Nakuru County. Prior to that, I worked with a number of development partners, basically in the area of good governance. Thank you very much, Dr.
Thank you so much, Waziri, and thank you to you both for taking time and accepting to share your insights so that the people listening, other people from other counties can really learn from your experience and get motivated by your leadership journey. So we'll start with you, Waziri. In a few years back in 2023, the government introduced so many reforms. There was the Primary Healthcare Act. That's when, again, the Social Health Insurance Act was introduced. The FIF Act that we dived into through one of our webinars a few months back was introduced, and all this, and then there was establishment of the PCN networks. All these things were happening at the same time. Different PHC reforms, including also the Digital Health Act 2023. So with the implementation of all these primary healthcare reforms, what opportunities did you see that emerged from your county? And what did you do to make use of the opportunities that emerged? As a leader, did you have any opportunities to make your systems better? Which opportunities are these? And how did you really make use of them?
So thank you very much for that. It's a very lengthy question. But I think the primary opportunities to advance Governor Susan Keka's manifesto, which is very, very heavy on the primary health care and universal health coverage. So for us in Nakuru, we pivoted very quickly and took the opportunity provided by those streams of reform that were introduced in the country. So, for example, for the Primary Healthcare Act, first of all, we have a very, very organized Department of Health. If I may say so myself. Very, very structured with very capable technical leadership. So I remember when the laws were passed and the Social Health Authority was put in place, and there were all these guidelines about primary health care and the FIF Act. The FIF Act, for us, we were already ahead with regard to FIF. But then when it comes to the PHC Act and the Social Health Authority Act and all the funds that came with that, the first thing that had to be done, and in terms of taking advantage of existing opportunities, was the county health management team took leadership of creating awareness of the contents or the aspirations of these reforms. I remember it was very difficult to explain to people the difference between, for example, for Social Health Authority, the SHIF, PHC, the Emergency and Chronic Illness Fund and all that. But we took advantage of every formation, every structured engagement, every meeting, every training to create awareness. The second thing was to create a governance structure that was really led at a high political level, specifically for primary health care. I do remember we set up a committee that was chaired by the county secretary to spur that change at that high level. So then there was no going back. Everybody had to align. We then charged ourselves with the responsibility of studying data, and I say the Department of Health in Nakuru County is extremely well organized. So we set ourselves up in the 11 sub-counties to study the potential networks to set up the primary care networks. And we decided to use our 16 or 15 existing hospitals. We left the level 5 hospital and utilized the 15 hospitals and made them hubs. We were very, very selfish to ensure that we took care of every single level 5, level 4 hospital, notwithstanding the fact that in 2 sub-counties, Elbagon and Olenguruani, we actually have 2 hospitals. But we say those sub-counties are very, very vast. So it is very important to have the hubs taking care of enough spokes to go around. We also took advantage of the leadership of the 15 hospitals. I'm leaving out the level 5 hospital. Took advantage of the leadership of the 15 hospitals to take leadership. We really inspired the leadership of the hospitals, primarily the ones that were led by the ones that are managed by family physicians. You know what the law says. And in those 5, I think we have 4 or so family physicians. In those 4 hubs, to make the medical superintendents champions of the establishment of these primary care networks. In very quick order, we had the 16 networks set up, gazetted, and rolled out. We have also taken advantage of, and all these laws and all these reforms are intertwined, by the way, and as you very well know. So, for example, in terms of funding the activities of the primary care networks, we made sure that the FIF resources were brought to bear to ensure that there is ownership at the hospital level, which are the hubs, to provide care for the spokes, which are the level 3 and the level 2 facilities. Maybe the other thing was to take, you asked me about taking advantage of existing opportunities. One of the opportunities that existed in the Department of Health was mentoring. We do have a very capable team of county health management team, and what we did, team members. And what we did in that year was to ramp up mentoring. We actually assigned each one of the county health management team members a hub, and therefore sub-county. And with that comes all the spokes beneath. So if myself, Rosalie Mungai, I'm the mentor of Kuresoi South, that means I'm in charge of Olenguroni Sub-County Hospital and Kiringet Sub-County Hospital, which are hubs. But I'm also in charge of ensuring that the spokes connected to those hubs are being supported, are having all the resources and capabilities necessary to provide services to citizens. These individuals sitting in the county health management, and I really credit human resource. These individuals sitting within the county health management team must ensure that services are going on in all the spokes, that technical support is being provided by the hubs to enable these spokes to continue to function. I think I'll stop there in the interest of time, but there are many, many other examples that I can give. Thank you, Dr. Ari.
Thank you so much, Waziri. And having worked with you, we salute you for being a leader on the ground. And on that note, it makes me wonder, how did you manage to engage the community and get their buy-in, on matters such as SHA enrollment, or, for example, getting them to understand that now they need to seek care at a certain facility that is within their jurisdiction, and that is their spoke in the PCN network setup. As a leader, how did you motivate the teams that you lead to reach to the community to get community buy-in?
Thank you very much. The biggest strength for our community engagement, by the way, is our community health promoters. And these community health promoters are supported by community health assistants and the entire preventive promotive team within the Department of Health. I do remember there was almost like a competition. You remember what I've told you just now about the mentoring initiative? So you have individuals mentoring the 16 PCNs and the 11 sub-counties. They had to then develop a rapid results initiative to ensure household registration by the community health promoters. And this message was really, really supported by Her Excellency, the governor, and all the politicians within Nakuru County, so that we had to really demystify what this social health authority is and why it is important to register to SHA. By the way, so far, we have a population of 2.5 million. I believe we've registered 1.1 million, which is just slightly above half. It's no mean task. It's very, very difficult to go around communities explaining to them the mechanisms and the mechanics of the provisions and the opportunities of the social health authority. So one, political buy-in and political mobilization. Two, really leveraging on the touch that the community health promoters have with every community member. Three, taking advantage of every community meeting. We'd go to churches, we'd go to mosques, we'd go to markets and pitch tents and get a registration going. We're still doing it. We're still trying to ramp up the registration, especially for the informal sector, which remains a challenge for us. The other strength that we have in Nakuru is that we've got very, very robust civil society formation. We cannot overemphasize the role of civil society in helping government to reach its people, and therefore inspiring civil society organizations and non-state actors, community representative institutions to walk the journey with us. And like I said, taking advantage of every single activity within the Department of Health and beyond, using the one government approach. There's another thing that I'd like to mention, which is very, very critical, which is that Her Excellency the Governor Susan Kihika's manifesto very cleverly and in such a proactive manner, promised to set up support groups for persons living with non-communicable diseases. Now, how are we going to do this? These are individuals who are living within villages, but who come to the hubs for care just because of the various levels of care within the county. We really had to engage these individuals during their clinics to tell them, look, there is an opportunity through the primary care network, and this is what the primary care network is. Through the primary care network, we have multidisciplinary teams which we are going to deploy to where you are. So wait for us where you are. We will link you up with the nearest health center, link you up to the nearest level 4 facility. I really want to congratulate the level 4 facilities, which are our hubs, for continually providing commodities to enable outreaches at the community level. Again, outreach is another mechanism through which we're able to reach our people. We've so far set up support groups for persons living with non-communicable diseases along all our 16 primary care networks, and they're thriving. Thank you, Dr.
Thank you so much, Waziri. I'd like to hand over the moderation to Dr. Brenda Obondo for her to introduce herself and take it up from here. Karibu, Dr. Brenda.
Thank you very much, Dr. Sally, and thank you for holding fort. I'm glad that I was able to make it and take it up from here. I think as Sally has introduced me, I am Dr. Brenda Obondo, and I serve as the Chief Executive Officer at Kenya Medical Association. We are the umbrella professional association for doctors in the country. And aside from championing for our welfare, we also do a lot of policy advocacy. And that is why this discussion is very important for us. From where we started with the healthcare reforms and where we are at now, how are we doing, and having the pleasure of having these wonderful leaders as our panelists today is really a great opportunity. So Waziri, it's really good and inspiring to hear as a leader how well you can articulate the detail of the work your county has been doing, and I think that's superb. And Oda, we are also keen to hear from you and hear on the data side and evidence and feedback. How have you utilized data and feedback mechanisms to guide your decision making, and how you've gone about implementation as a county on these reforms? Dr. Oda? Yes, karibu.
Thank you, Brenda, for that question. And Waziri, thank you so much. For a moment there, I thought you were one of the TOTs for establishment of primary care networks, because you are on point. So, Brenda, allow me, I will take you back to the 1978 Alma Mater Declaration that defined primary healthcare as the key to achieving global health for all. Health was declared a fundamental human right and emphasized that community participation, preventive medicine, and equitable access to care. So Alma Mater remains our fundamental framework for global public health policies aimed at strengthening health systems. Now, come to the year 2015, where we had the Sustainable Development Goals that were set. Now, these Sustainable Development Goals explicitly define the global health targets for 2030. We are in the year 2026, so we have 2 years to the year 2030. We are supposed to reduce our maternal mortality ratio from 300 75 per 1,000 live births to around 70 per 1,000 live births. Are we really on course? And our neonatal mortalities now are at around 41 per under 5 around 41, and our neonatal at around 21 per 1,000. So looking at this and looking at data from our KHIS, why primary healthcare? So as Nairobi City County, we have recognized that PHC delivers essential prenatal care, skilled birth attendance, and also childhood immunization at the local level. Apart from our maternal and neonatal mortalities, we are also looking at our NCDs. I'll go back to our SDG target 3.4 that aims to reduce the premature mortalities from NCDs by around a third. How are we doing? Looking at our KHIS data, it shows that non-communicable diseases are now competing closely with communicable diseases as the leading cause of national mortalities in Kenya. As we are establishing primary care networks, this is what we are having at the back of our minds. First, the Alma Ata Declaration. Second, where are we going as a country? And thirdly, what is our day-to-day data telling us? Our last KDHS was in 2022, but now we cannot just depend on that data. We need to use data from our KHIS, data from our hospital records. And now that we have the digital health and the digital superhighway, we are using EMR. So this data that we get every day is what is guiding our PHC implementation. Those are just a few examples of how we are using data in decision making. Another thing is that in Nairobi City County, we do what is called targeted outreaches and targeted enriches. And this is from the data that we get. If we find that this community is having a lot of teenage pregnancies, we use that data to go to the community and now give targeted outreaches on family planning. If you are having a lot of members coming with chronic diseases that they have been caught late. So this is now for us to give intervention using our multidisciplinary team through the primary care networks. Thank you. Back to you, Brenda.
Thank you very much, Oda. Allow me to sneak in a question because we were at a meeting today. And I'm just curious. So what does it mean for Nairobi County, the every woman, every newborn, everywhere, and the rapid response initiative that has been launched today? So the numbers you're stating on maternal mortality, newborn mortality. So just in a sentence, what does that mean to you? I know you hadn't prepared, but I just wanted to catch you from that event that we just came from.
Yes, for Nairobi City County, this is what we normally say. That's the health of a county. Now, it's usually the health of a country, but for us, it is the health of a country is defined by the number of maternal mortalities and the number of neonatal mortalities that we have. So for us to say that Nairobi City County is a healthy city, our numbers have to be reducing. And Dr. Brenda, I can assure you that since 2023, our absolute numbers have actually gone down from around 180 and now we're around 150. But one mantra for Nairobi City County, we are actually not looking at SDG goal number 3.1 that we need to have at least 70 to 100,000 left, but for us it is 0. Our target is 0 maternal mortality rates, especially the ones that are preventable. That is what it means to us, Brenda. Back to you.
Thank you very much, and thanks for gracefully taking on that. The work you're doing in your area is really inspiring as well. So, Dr. Oda, allow me to engage you a little more on what Nairobi County has done in engaging the community as far as primary healthcare reforms is concerned. Because as we know, PHC, the heart of PHC is the community. So how are you guys engaging Wanjiko, Achie, Naisoi, when you're going about these reforms?
Yes, Brenda, thank you so much for that question. Now, in the establishment of primary care networks, we have 8 steps, and one of the steps is the questionnaire to the community health promoters. Now, for Nairobi City County, this is what we do. Our community health unit has 10 promoters. During our assessment in the field, we gather all the 10 promoters in the CU. So if a facility has 8 CUs, we are going to administer this to the 80 community health promoters, and it is 10 per CU. So why do we do this during our establishment of the primary care networks? You and I know very well that some of our healthcare workers don't get the reforms and policies that are formulated and passed at national level. So how will a CHP have these reforms if a healthcare worker does not have? Now, during this field work, we normally at least sensitize these CHPs on the reforms, and they know that now they are not working alone. Previously, the CHPs could go to the household level, they see a patient and they don't know what to do. But after the establishment of primary care networks, the CHP know that there is a multidisciplinary team, and there's a multidisciplinary team lead. So in case they encounter a patient in the household that needs urgent care or needs consultation, they know whom to call. Apart from calling the CHA, because there is the channel where they call the community health assistant, the CHA calls the MDT lead. I'll just give a practical example of how we are engaging the community through the CHPs. Our first PCN was the Makadara PCN, and in this PCN, there was a CHP who had a patient who had stroke for over 4 years. The patient was obese and bedridden, being taken care by the husband. After establishment of this PCN, the CHP was able to contact the MDT lead, and the MDT lead went to the household, assessed the patient, and found out that this patient does not have any urgent or emergency issues apart from lacking physiotherapy, psychotherapy, and nutrition counseling. In the MDT being a 15-member team, they were able to visit these patients, and this is the year 2024, on a monthly basis. Right now, as you speak, Daktari, this patient is mobile and is able to do activities of daily living by herself. Why? Just because government employees, we decided to go to the household to offer these services to these patients. So now, as we are trying now to bring policy into practice, and this has allowed us to visit households without any fear, knowing that we are backed up by policy. Thank you.
Wow. I'm a bit dumbfounded. I think this PHC reform is really an impactful journey. And Waziri, in regards to partners and partner engagement within the counties and of course the national government in support of the recent healthcare reforms that we've had, we know the critical role that partners have played. But of course, now we are looking at expanding our sustainability and being able to resource primary healthcare and transition towards us being able to fully support it. What has your engagement been like, and what are you guys thinking as a county, even as we build on this transition of being independent as far as sustainability is concerned?
Thank you very much, Dr. This is my favorite topic, sustainability. And it's very, very difficult to crack within government. You know, I think I said earlier in my introduction that I come from a development background, and we used to preach sustainability. It's not as easy to say from the outside as it is. I mean, from the inside as it is from the outside. But however, this is the only way. Development partner support is highly appreciated, highly acknowledged, and highly valued. But it can never be the mainstream. The mainstream has to be government ownership. That has been my position within the Department of Health. One of the best things that has happened in Nakuru County is long before even the change in US foreign policy, UK foreign policy, everybody's foreign policy about development aid, is that we decided we are going to rally all our partners around the county integrated development plan and our own annual development plans for every year. So at the beginning of every year, like now, this is the season for annual work planning. The development of the ADP, is then followed by an annual work plan. We bring all our partners around a table and we show them what the priorities for the department are for the next 12 months. And then we request the development partners to plug in. They are very, very agreeable. So they sit with us. They will tell us what resources they have already in their coffers and what is likely to come, but we try to fit them within the priorities of the department. This initiative also has been supported by a mechanism where we have a partnership committee, which is chaired by one of our directors, the director now for administration and planning, before then to the director for medical services, so that we also know what every development partner is proposing to help us with. And we are honest enough to say, listen, development partner Hector, this support has already been provided by development partner Amref. Which other item can you pick? They're also able to speak amongst themselves and see how they can collaborate and how they can layer. We are very big on layering. The other thing is we try to ensure that as much as possible, development partners have got the game-changing ideas. They have a lot of time to read, to research, to consult. Me, I'm just busy running from one crisis to the other. So what I say is, help us by developing the capability of our technical teams to be as good as you are. So one of the examples that I can give is not just because the webinar is hosted by Hector, but we had a conversation about developing the capability for data analysis and utilization of data by the primary care PHC committee. It's called the PHC committee within the Department of Health. And so every month they have to sit and look at what the data from the dashboard is telling them or is telling us. And then, like Dr. said from Nairobi, If it turns out that in Rongai, the biggest challenge is in terms of disease burden or practice or whatever it community practice or whatever it is A, that is what we're going to focus on. So the team already begins to see how they can utilize data to improve service delivery. This technical capability and technical assistance cannot be taken for granted. It is a sustainability measure. Because we had a very, very bad experience in, I think it was 2025, when the US stop work order was introduced for HIV, tuberculosis, and women, women and children's health. It was one Friday morning, and we were told all your 200 plus, in fact 300 plus healthcare workers are no longer embedded within the Department of Health. We worked overnight on Friday, on Saturday, on Sunday to make sure that Monday morning, that CCC clinic had better be run. That FP room had better be manned. Within the 2 months that Tujenge Jamii was out of the picture in Nakuru, we reorganized ourselves. We integrated all our services within outpatient departments across all hospitals, including the level 5. We developed such a good collaboration with Tujenge Jamii that even when their staff were not working, they came to our aid to develop capability to use the EMR, because the EMR only was being used within the comprehensive care clinics. Let me tell you, by the time Tujenge Jamii came back to Nakuru, because they had been reinstated, we were now ready to provide leadership. We introduced what is called a county-led initiative. The Tujenge Jamii staff that are embedded within the health, within the Department of Health and across all our 227 facilities had to come and work the way we working within those 2 months. It has really worked. The interaction is seamless. The capability is growing. We are now prepared. Should it happen again, it won't hit us as hard as it should. What am I trying to say? The sustainability can only work if government takes ownership, number one, takes leadership, and provides accountability. Very, very important. We also must continue to inspire our healthcare workers who are so technically competent to push the needle in terms of providing support for our primary level facilities. We say, do you know whether the 27 facilities within your sub-county that you mentor opened today and stayed open? Do you know whether the nurse that is working there had an emergency and had to leave? And if they had to leave, what did you do as a mentor of that sub-county? Did you ask the sub-county health management team to deploy somebody capable, somebody clinical to go and provide services? Beyond what the development partners can do, we must do for ourselves. And the other thing is about resourcing. One of the pillars is about financing. In Nakuru, 100% of FIF from years ago is retained within the Department of Health. The funds are not commingled there at the Exchequer. We actually dedicate all our resources or plow them back into the health facility. So now with SHAP, the reimbursement that is coming to the primary level facilities through the Primary Healthcare Act is following the same trend. There is a budget committee and an AIE committee that looks at the resources that have come to that facility called Aremi in Molo. You've received this amount of money through the primary healthcare fund. What are your priorities? Show us the minutes of your facility HMT together with your the committee, the health facility committee. What did you prioritize? And it had better be a long service delivery. So we've given them a set of, like a criteria or a protocol. First, the core mandate, commodities, reagents, cleaning, supplies, and then all the other supportive infrastructure. If your window panes are broken, please fix them also. Those sorts of things. And then slowly we move towards development. What am I saying? That the FIF Act and the FIF resources are also a huge contributor to sustainability. Her Excellency Governor Susan Keka in Nakuru has consistently dedicated 40% of her budget to the Department of Health. The bulk of this budget obviously goes to human resource for health in terms of salary and benefits, but a large proportion goes to commodities, especially for the primary level, because we expect the FIF generating facilities, the labor force, to try and take care of themselves. But now we are thinking through how to support our labor force facilities that are providing primary health care the same way that we support the primary level facilities. Thank you, Dr.
Wow, thanks very much. I think what I pick from Nakuru is just you guys being able to build a system that is fueled by accountability and also allowing people to lead and take ownership of the process. So it's an all of person approach. So that's really a key point that we need to take note of. As we proceed, and before I go on to engage my panelists on the last round of questions, I'd urge us to please engage on the Q&A section. Please ask your questions. If you have any comments, please feel free to drop that as well. And if I can get concurrence from the team, if there's any, are we allowing any audio questions? Dr. Sally?
Yes, indeed, Dr. Brenda. I mean, I think
All
we
right.
should allow where necessary. Thanks.
Okay. So please, if you have a burning question that you'd love to ask on audio, you can just raise your hand and we'll be able to unmute you for that. But meanwhile, please post your questions. We'd love this to be as interactive as possible. So Order, over to you on Nairobi, and Nairobi, of course, being an urban area. And we know the urban health challenges that come with that environment. How have PHC reforms been adapted to meet the needs of that large urban population? Because you have a huge population.
Yeah, Brenda. Being this PHC coordinator for around 5.1 million people is quite humbling. Now, Nairobi is the third smallest county by surface area, but it is the most densely populated, as I've said, with a population of around 5.1 million people, according to KNBS demographic population projections, and about 60% of them are living in the informal settlement. We might think that since you are a capital city, then healthcare is easily accessible and affordable to our people, but that's not the case. So just a brief context, currently we have about 1,200 healthcare facilities across all the care levels and ownership. And of this, about 17% are our own public facilities managed directly by the government. This means that the public health facility ratio per population is severely constrained at about 3 public health facilities per 100,000 residents. So just think about that as we're trying to make sure that these reforms work for our people. WHO says that we need to have around 24 facilities, and now I'm talking about 3 facilities. Level 5 facilities, not really level 5, yeah, level 5 and above facilities, it's supposed to be 1 for level 6 rather, 1 for around 1 million people. How many level 6 facilities are there in the city, publicly owned? Is it 1 or 2? So how many level 6 facilities do we need? Let us go down up to level 2 and 3. So look at that. What has Nairobi County done with these reforms? I'll still go back to the experience that we have had, and Makadara Sub-County or Makadara PCN is my model PCN because it was the first one when we were doing all these. A practical example is that Makadara has a population of around 262,000 people. It has about 42 facilities, and only around 10 are public health facilities. Now, there's a ward. Makadara has like 4 wards because for us, healthcare, we start from the county level, sub-county level, ward level, up to the village level. So I will just remain at the ward level. Now, there's this ward. It has 4 wards. There's this ward called Makongeni ward. This Makongeni ward has a population of around 80,000 people. During our assessment in the PHC establishment process, we noted that there were only 2 level 2 facilities serving a population of 80,000. In this level 2, one was our own public facility and the other one was a private facility. Our establishment for primary care networks in Nairobi City County is just not about finding gaps. After finding gaps, we find solutions to these gaps. What did we do? We used this as evidence for advocacy and resource mobilization for this particular ward in this sub-county. Today, in 2 years, we have built a fully modern maternity and theater in Makongeni ward. This is Kaloleni Hospital. I invite you, Brenda, during your field work to actually visit and verify that what I am saying is true. So this ward has been there for how many years? But now it just took the PHC network establishment, the PHC reforms for people to actually see that they can have public-private partnership. Now, this facility was built by Church of Latter-day Saints. So now I'm saying, apart from government, the PHC reforms have actually enabled us to practice the public-private partnership with no fear. Talking about public-private partnership, again, I mentioned that I have around 1,200 facilities and I have 5.1 million people. If we don't work with our public and private facilities, then we cannot give our communities the affordable quality health that they need. Another example, I like giving practical examples because that is where we are. in the year 2025, we had an industrial action. And we had a patient who was identified again by a CHP. This patient had high blood pressure and signs of a stroke. The patient was referred to the MDT lead. A CT scan was done, but remember, we were having an industrial action. Now, during the establishment of our primary care networks, we involve all the facilities for the baseline assessment. And before going to do the baseline assessment, we call these facilities, we sensitize them on the 4 UHC acts. My CEC has talked about the 4 UHC Act, the SHARE, the Digital Health Act, the FIF Act, and the PHC Act. Now, we go to the field, collect data, analyze the data. This data is analyzed by our own sub-county teams. Why do they analyze this data? Because we want them to know their sub-county better, to know their facilities better. They write a report. This report is disseminated to all the facilities. So as for Makadara, it had 42 facilities. We disseminated this report. Now, in a sub-county, you might get a facility that is not a PHC facility. This is a level 5 facility. For Nairobi County, we don't leave them out. They might not be part of the network, but it is good to know that this facility exists and these are the services that they offer. Back to my patient. Now, after the CT scan was done, our MDT leads could not consult any of our radiologists because definitely they are having an industrial action. Because of the good relationship that we had with the private level 6 facility, we were able to take that patient there. The CT scan was interpreted and the consultant at level 6 started this patient on the appropriate management. Today, we averted a stroke because of this relationship that we are having with our public and private facilities. So that is what we are doing. We are trying to build more facilities, but also work together with the facilities that are there. The other day, I was in a meeting with the urban planning, and the urban planning department thinks that we have so many facilities in Nairobi City County. But after giving them a presentation of how many facilities we need per population, they agreed with me, and they are actually considering giving us a space to establish more primary healthcare facilities so that we can just make these quality healthcare accessible to our people. That is all I have for now, Dr. Brenda. Back to you.
Thank you very much. I see you're a great student, yourself and your team of evidence-based advocacy. If you're able to convince the urban planning guys that you actually need more facilities, which also ties to how you guys have utilized data and to demonstrate what the need is. That's really important. Even on this journey of reforms, policy advocacy is something we cannot miss as we go on. And it's something I've been able to pick out from both Waziri and yourself in how you're engaging the community and also how you're engaging with the reforms themselves. So Waziri, I want to poke you a bit in regards to what the journey has been like. Of course, it's not been smooth, it's not been perfect. There must have been hurdles along the way, being new laws that had come in place and trying to organize and reorganize and set up a framework to implement. What has kept you and your team motivated despite the slow progress or the setbacks you may have faced?
So you're right, Dr. The setbacks have been there. There have been many hoops to jump, many hurdles along the way, some more difficult than others. So I think the most complicated one to navigate has been the Digital Health Authority Act and the Social Health Authority one, just because it's very difficult to change people's mindsets. I was with you today and we were discussing this, every woman, every newborn, everywhere initiative, and the president speaking about how the reform that brought about the Social Health Authority has actually turned around our facilities. It took a long time for people to see this. People, the community, citizens, leaders even, within Nakuru were a little bit doubtful because obviously they were used to NHIF. And the biggest challenge in explaining was this Linda Mama. And it didn't make things easy when the PHC fund a couple of months ago stopped reimbursing primary level and level 4 facilities for maternity service delivery. So what keeps us going, or what keeps me going? Number one is I believe in the cause. I'm in Nakuru to help Her Excellency the Governor to deliver on her manifesto. That is my commitment. That is my path. I'm going to do it, come rain or high water. So we must figure out the journey. The politicians, the political leadership does not provide you with a roadmap. It tells you where they want to go. At least that's what my governor does. She tells me this is where I want to land with regard to universal health coverage, and now you figure it out. But because I'm very driven, I'm a very driven person, I'm very results oriented, I believe in data and using data for decision making. But more importantly, the thing that keeps me going the most, apart from all those things which are in the psyche of my being, it's in my morphology, is the fact that I'm not a medic myself. And so I know I must trust the process that is presented by the healthcare workers, the medics and the non-medics, the people who work in the Department of Health. So I harness all those energies and I try to sharpen them for governance, for program management, for monitoring and evaluation, and particularly for data review. Once I have inculcated in the team that spirit of utilizing data, being honest about what the data is telling us, and being proactive to develop programs that will help us to address that data, then there's no turning back for me. And because I enjoy my job, Daktari, it's actually not a job, it's fun. It's a lot of fun. Working with the medics, they're one of the brightest people we have in our communities. All that we need to do, this is my opinion, all that we need to do is to bring our world into their world. So our world is social development. My world is social development and good governance. Their world is medicine. Just ensure that it all works in a seamless manner, that they can see the end from the beginning and they are committed. You motivate them. Her Excellency, the Governor, has really given me a lot of strength by listening. She will listen when you tell her, listen, the healthcare workers are trained in terms of workload. We need to increase our allocation for HRH. And that has become her clarion call to the County Assembly of Nakuru. When you tell Her Excellency the Governor that we need to figure out equipping as part of development, she gets it immediately. So the fact that our development now, when you're building a facility, you must budget from the brick and mortar to the equipment to the human resource for health. Because I can see that full continuum in her thinking, I'm motivated to keep going. I'm also extremely motivated by the growth that I have seen. I think Daktari from Nairobi, the physician from Nairobi who is managing primary healthcare, has really drummed up support for change, visible change that you're seeing in Makadara and other places. I can tell you, the Lanet Health Center in Nakuru East that existed a year and a half ago is not the Lanet Health Center that exists now. They are independent. No, they're not independent. They are what's that word? They stand on their own. The Mount Narok Health Center that was there 2 years ago is not the Mount Narok Health Center that we have now. Because of this support from the regular reimbursement by SHA, they have actually built a maternal shelter for women coming from as far away as Narok to come and chill in the facility and wait for their babies to be born. And they will be fed with that money from SHA, so that we can reduce negative outcomes or poor outcomes, but also so that we can reduce home deliveries. I have seen personally community health promoters being able to walk around their communities, map pregnant women, and bring that data to the dispensary. And that dispensary organizing Group A and C to take care of those mothers. The future can only be brighter. And so I don't see the problems. I see the opportunities and the successes. Thank you, Dr.
Thank you very much. And I believe, Waziri, your expertise has been instrumental in getting Nakuru where Nakuru is now in terms of implementation of the Primary Healthcare Act. I would just love for us to take a few questions. And I'll just pick out, I see we have 3 questions on our Q&A. Dr. Oda, in terms of the reforms, anything we should be looking out for in the future? I think that must be a Nairobi County resident. And another question for Dr. Oda, what is the percentage of SHA uptake in Nairobi? If you have that number, that would be great. Then finally, there's a question from Ayana. How can we improve our digital workflows to better coordinate care and referrals across different specialties? I know, as you've said, that particular digital platform, or rather the implementation of that, has been a challenge, but I'd love you to take this question from Ayana. So Dr. Oda, you'll start us off with the first 2, and Waziri, you can tackle the second.
Yes. What we need to look out for in the future. Now, this one I'll be speaking to our government colleagues. I don't know if the question came from a member from the private sector or government, but the government colleagues, we need to up our game, because with the new reforms, it is equitable. Like there's the Social Health Insurance Act is not favoring government or public. The primary care networks is not favoring public or government facilities, because we can have upward and downward referrals to any facility. It is opened. The Social Health Insurance Act, PHC Fund, allows a patient to visit any facility. So if we are not going to give quality care to our patients, and we are not going to have our drugs, our laboratory tests, definitely most of our patients are going to go to the private sector, and that means reimbursements of SHA might reduce for our public facilities. And that takes me to the second question about percentage of SHA uptake in Nairobi City County. I will speak to public health facilities again. All our 124 public health facilities are registered on SHA, and they have received reimbursement, whether there's the SHIF or the PHC fund, and our level 2s and level 3s have received the PHC refund. And I just want to challenge, the way I challenge Dr. Brenda to visit one of our facilities. I need you to visit any of our government facilities, level 2 and level 3. You will see change. We have drugs available. We have laboratory equipment that have been installed using these social health insurance money. Over to you, Dr. Brenda.
Thank you, Dr. Oda, for that response. Waziri, on the workflows.
Thank you very much. Indeed, this has been not a walk in the park in terms of digitalizing. And again, this is one of the flagship projects within my governor's manifesto. But the biggest challenge is twofold. One is the coverage in terms of connectivity, because most of our primary level facilities are obviously in far-flung areas with very poor coverage. In spite of that, however, close to 100% of our facilities are now digitalized. I walk into a facility and I don't, well, let me not say the registers have diminished or disappeared. They've not disappeared, they're still there. But you also see the little iPad, not iPad, that thing, tablet, and the nurses, clinical officers, they tell me it's so much easier. It's even easier for them to call the sub-county MOH, the sub-county team leads or the MOHs to order in terms of the things that they need. Because, for example, maybe there's a requirement to use a pulse oximeter and it doesn't exist. You just have to buy it because the data is needed by the portal. So there is no turning back where digitalization is concerned. We have to address the second level after addressing the connectivity. And the second level is enabling our healthcare workers to become digital themselves. Obviously, we have an aging workforce. We do have an aging workforce. And we are trying to ensure that our older generation healthcare workers are paired with the more, digitally versatile Gen Z type healthcare workers. The same case with our community health promoters. Obviously, they have the ECHs. They have the tablet that enables them to load the data onto ECHs. But it's an old lady, and she's very, very happy to work in the community and to help our people. And the last thing she wants to think about is this tablet or this smartphone. It's very, very difficult. And then coupled with that is the slow pace of whitelisting of these phones that the CHPs use. And so they spend a lot of their resources to load the data. We have tried to resolve that. It is work in progress. But the future, because this person asked, how do we improve our workflows? For me, We have an example in Bahati where we have a smart PCN. Smart PCN means you can actually have a referral from the community by a community health promoter to the dispensary, from the dispensary to the health center, from the health center to the hub, which is the level 4 hospital, and all the way back using the tablet. For me, that is the future. We only have one fully smart PCN. We need to make all the PCNs digital. We will have to work together with a lot of fear and trembling to do away with the paperwork, and the nurses who have to walk to take a Buddha and travel 5 kilometers to take the monthly report. That has to come to an end at some point. Thank you.
Yeah. I think what I gather is that digitization is inevitable and will definitely drive the growth of our primary healthcare, our PCNs. So digitization is inevitable. So we gotta get onto that. I think I'll take responsibility on behalf of other healthcare worker associations to be able to focus on, building the capacity of healthcare workers, across board, across cadres on this, and just focus more on CPD that will strengthen our capacity in that area. Finally, I don't know if I'm missing any questions, but I'd like us to wind up because of time. I know that Hector and KMA will be planning more of this series on primary healthcare as we proceed, and we look forward to engaging. We'd also love to hear from you what your views are on what more you'd want to engage on as the participants on this webinar, and what your thoughts are on the direction we should take in terms of advancing these discussions, so that we come out with beneficial, tangible outputs that will support our ongoing efforts in primary healthcare. Waziri and Dr. Oda, I'd request that you share a parting shot, whatever that looks like for you. If it's a key lesson learned, if it's a proposal going forward to the audience, if it is a suggestion, or you'd want to leave us with a phrase, please give us your parting shot for this webinar as we close.
Yes, Dr. Brenda, I'll go first. So, with the reforms, the implementation of the PHC establishment of the primary care networks, making them operational, this is what I can say. And during my training, I normally say, and I'll just repeat it, PHC is not a project. It is a commitment to the people, and us in the leadership position is what we are going to sustain this commitment. We have the UHC Act that are backing every decision that we make. So anyone in leadership and also anyone just giving services to the people, they need to know about these acts. They need to embrace them. Remember, we made a commitment in 1978 during the Alma Ata Declaration. It was renewed in 2018 in the Astana Declaration. We have the SDG goals and we have the Africa we want. So if we take these, then we are going to beat some of the first world countries in delivering quality, affordable, and accessible healthcare. Thank you, Brenda.
Wow. What a parting shot. Waziri?
Thank you, Daktari. And before I give my parting shot, by way of accountability, somebody asked a question there, and I think they're from Nakuru. They asked how prepared we are for Ebola. And I think it's only right that I use this opportunity to answer that question. We are very prepared. We have activated the rapid response team as required by the protocols. We are training our healthcare workers and giving them all the information that is coming out of the Ministry of Health. We are preparing our commodities. We are aligning our PPEs. We have identified isolation centers across the county. We have identified a quarantine center. We are providing public education using our CHPs. We are still at the foundational spaces. So we are prepared. We are really, really hopeful that the virus does not cross the border, obviously. But in the event that it does, we do have a mechanism in place. The Ministry of Health is really spurring us. We are having nightly meetings such as this, but to plan our IPC, our infection prevention and control initiative, top big gear across all our 227 public facilities and over 200 private facilities. So let me leave that at that. Maybe there'll be another opportunity for us to talk about that. And by the way, now in terms of parting shot, let us not throw the baby with the bathwater. For people who are not in the healthcare space, it is very easy to criticize and to throw stones. And that is why Daktari keeps telling you, Dr. Brenda, come and visit me. Please come and visit me. Come and show you the things that we have done. The same thing that I tell bloggers, the same thing that I tell social media activists. That hospital you're talking about, that is, according to you, it is at ground zero. Come, we show you. Because you have to be in the practice of medicine and service delivery to understand how healthcare workers bend over backwards to provide services to citizens. That nurse who is working in that facility called Murindoko in Kuresoi North alone requires our understanding and our support. That is a person who is the face of primary healthcare. The same way the CHP who comes and knocks on your door and you shun them, that might be the difference between life and death for a mother somewhere. So let's not throw the baby with the bathwater. Let us open our minds to learning and to seeing the change that is happening. Let us support the initiatives that development partners are introducing in Nakuru. For example, a dashboard that was introduced by Hector to track primary healthcare is now being adopted by the county. Many platforms like along the every mother, every newborn initiative, those sorts of things for maternal and child health. The SMS prompts to mothers that were introduced by Jacaranda are now county health prompts. We are owning and we are taking your health very seriously and programming with a lot of fear and trembling. Thank you, Dr.
Thank you very much, Waziri. Change management is usually something that is difficult, but I think these healthcare reforms have shown us the need for being able to manage change. And with that, allow me to just pick out a few points that for me really stood out with this webinar that we've had with these great leaders. So the government has to take ownership, leadership, and accountability, be it in financing, be it in strategy. So the government needs to lead from the front, and I'm glad that the president mentioned that today, that I lead from the front, and it's great to have that kind of leadership. And really with primary healthcare, the continuous community engagement and sensitization. I've heard you guys speak a lot about how you keep teaching, you keep engaging, and you're really in the community as departments of health. And of course, the strategic and useful use of data to inform how you're having your implementation, even how you're setting up the PCNs. So this data-driven decision-making cannot be underestimated. And if there are other counties that are having trouble doing that setup, turn to your data and use that as you move forward. Then, of course, collaboration. And for me, this was important because you need different people with different expertise on the table to be able to drive this forward. Collaboration across cadres and also across expertise, and steady intentional growth with, of course, county initiatives. Nairobi will not look like Nakuru. Your challenges are different. Everything is unique. Your populace is different. So just understanding the community you serve and working around that for growth. Then finally, for me, would be a challenge to, of course, all the counties that would be attending this webinar and those of us working within those health departments. I've had a lot of really interesting initiatives and strategic direction that these two counties are taking. And I believe that the other counties also have their own success stories. So leveraging from the experiences of each other and learning from one another would also be a great tool for us to take advantage of. We don't have to go and benchmark anywhere else other than the next county. So having that collaboration is important and cross-learning. With that, I would like to thank my panelists, Waziri. Continue with the good work you guys are doing in Nakuru County. We really appreciate your leadership there and what you guys are doing, specifically with primary healthcare. Dr. Oda, you guys today had one of your facilities won an award. So keep it up. It means there's something good we are doing, even as healthcare workers, and we also need to encourage ourselves and pick up and keep going, as Waziri said. Just put in the work, and at the end of the day, we see the fruits. So keep going with that, and thank you very much for gracing this webinar and for sharing that story and your experiences as leaders. I'd like to thank the participants, of course, for logging on. This conversation is important for each and every one of us, and we'd love to also highlight your stories. Please reach out to us. KMA, we have the KMA website, kma.co.ke, Hector Consulting as well. You can be able to just reach out and see how we can plug in and advance these conversations. Thank you very much, Hector, for the partnership, and of course for the work you're also doing in primary healthcare. Keep doing what you're doing and also advancing the implementation of this act and being intentional as partners in supporting the counties with what they're doing. And finally, we thank God for this. I'm not sure if we had a prayer before Sally, but asanteni sana.